Okay,
There we go.
cool.
Awesome. I'm actually trying to pull up the question right now.
I got them. How would you rank the level of safety and care provided on your unit prior to the COVID-19 pandemic?
Oh, prior.
I didn't work there before COVID. I mean, I could go off of my old hospital.
Okay.
So well, at least with my unit with COVID, we didn't take any COVID patients at first. And then toward the end, like last August, we started taking, if we had a positive patient, we would send them out. But while they were waiting for like the couple days for it to come back, they would be on our floor, which I never really understood why we sent them out when they were positive. They'd already been there for a couple days.
So you already.
Everyone was exposed. They might as well just keep them. But after that, maybe in December, I guess they realized that wasn't the smartest thing, and we would like not take them, period.
You want to go to Anastasia?
So prior to COVID, I wasn't a nurse on the floor. I worked on that unit, but I was a healthcare tech. And I know it's hard to answer the question because I guess I would be looking at it from a different perspective, but COVID wasn't a thing. So of exposure, I guess, was not necessarily a concern. So when I think of safety, I'm thinking more things of like fall prevention. As a nurse, I wasn't necessarily focused on infection prevention. So I guess in my role, I was more concerned with like fall prevention, making sure that any vitals or blood sugars that were abnormal, I was communicating that to my nurse. If anything, like look, because as anything that looked abnormal on my patient's skin when I was doing like bathing and changing and stuff, I made sure to report that to my nurse. And then of course, if we had any patients that were on some sort of isolation precautions, like C. diff or CRE or VRE, I would make sure to gown up and properly do hand hygiene. So I think in that regards, we did fairly well. Yeah, for the most part, I think we did fairly well. And we would make sure, if we saw anyone that wasn't performing hand hygiene before going in, I forgot what that phrase was. We would say something like, do you need a hand or something like that, just as a reminder.
Okay.
So y'all said the ranking would be like 1 being the best and safe and 5 being the lowest. How would y'all say? 1, 2-ish?
I would probably say a 3 for my floor,
3?
just like an average, because like they've done some really stupid things, but they kind of fixed it. So it's like we're good now, but the first it was a little iffy.
You agree?
You said 1 being the best and 5 being the worst?
1 being the best and 5 being the lowest. Yeah.
I don't think any floor is perfect, but I think I would give us somewhere between a 2 and a 3. Maybe let's go with 2.5.
Okay. Well, me being a freestanding ER, as I done the charge, we had a lot of helicopters coming in, taking patients in and out. This is during COVID and prior to COVID. And people forget that we need to turn off the sprinkler systems, because if the helicopter's trying to land and the sprinkler systems is on, they can't see the ground. So the ground's like moving. So they could actually land on top of the ambulances, or they could land on top of us and blow us all up. So that we had to make sure that because some of the staff was like, why are you worried about the sprinkler system? Well, we could blow us all up. So that was one priority. So we actually did an in-service, because a lot of people didn't even know how to turn the sprinkler systems off, including our police officers, security guards, that's what they're supposed to do, because they call the fire department and we sometimes have to shut down Lane Street. So that safety wise, that affects both us and the community, because if that would have happened, we'd have had a big mess.
Yeah.
Because I didn't even think about that till you brought up about the care partners, about the GBSs and all that stuff. So that's a good thing. Thank you for mentioning that. And the other thing, we've had quite a few of shootings in the area. So they've actually thought about getting us a metal detector, so that, because we don't have one like Northeast does, but being a freestanding freestanding. We don't have that. So we have one security guard. So we, as the charge nurses, you're part of the security. So you're going around making sure everybody's okay as well. So you're right. Nobody's perfect, but I would give ourselves about 2 or 3 too. Now, when COVID hit, all bets was off because we actually have everything in, we have 16 rooms. Everything's in the room. So we had, including the linen, the IV stuff, everything. So we had to actually take the rooms out. So the only thing we left in the room was a stretcher. We had to take the curtains down, the blinds. We put over, in the ICU, they have the clear stuff. When you shut the door, it covers up so you can't see anything.
Mm-hmm.
I don't know if y'all know, I don't know what that's called, but it costs too much. It costs us like $5,000 to do a room. So we actually took wallpaper and covered the windows and the doors so for help protection, so that we didn't have to clean those rooms and curtains, because it took 45 minutes to actually redo the rooms when we had to clean them. So that was one thing where we did. And then we had to take all the supplies out. So as a nurse, like if I went in to go to a COVID room, because we had certain rooms that were set aside for COVID rooms, we would say, Cody, I'm going in this room. If I'm not out in 15 minutes, call me. So you'd pick up the call bell and say, hey, are you okay? Do you need anything? So we use the call bell system when have one person go in, and we'd leave out the EKG machine or whatever outside the door, and somebody would hand it so that you didn't have a ton of patients and staff in the room. You only have one. So that one nurse would kind of take care of all the COVID patients. And then she would be off for a couple of days and come back. So that kind of cut down with us being in with COVID patients, everybody. Does that make sense?
Mm-hmm.
I was actually there when they started putting up like the paper on the door.
Yeah. Do you remember? I started to say,
Yeah.
I thought yeah. And then we also done screening, because we didn't have a screener. So that kind of helped. We kind of knew, we divided the ER in 6 side, well side. You go over here and you go over there. If they had no visitors, they stay in the car. We'd write their telephone numbers down, and then we would talk to them and call them and let them know, so we wouldn't have so much tracking in the ER. So that was different, because we never done that before. And I forgot to say, going down, it says, what changes would you make in how would you rank the safety and the care provided during the pandemic? We already talked about. Now we'll start packing that. And then it says, what effective communications or procedures and policies changed during the pandemic? And how did your communication change over the time? What worked well and what didn't work, and what is your suggestions? So I'm sorry, I should have said that, but we kind of jumped into that. I'll shut up, y'all go.
Fine. If you want to go, Cody, you can, or I can.
Okay. So some of the changes that we did for communication was we actually started using the call bells too for like our PUI rooms. And that was kind of like a little iffy. So what we did after is we had like at night, they couldn't do it during the day, but we had a bunch of like the extra care partner phones, and we would actually like give that to the patient, and that we could like call them or they could call us. That way we could do a one-stop shop of like, okay, we're going to come in here, we're going to gown up, we're going to be ready. I'm not going to be running back and forth, because I don't want to like go through all that PPE. And that was back when wear was like basically none. That was like last summer. So they're like, you get like one gown for like this patient.
Mm-hmm.
Use it wisely, don't rip it off, don't throw it away.
Right.
So, and then, I mean, now obviously that's not an issue, but that was one of the things that they did that I actually thought was kind of smart, was the phones.
Mm-hmm.
We got walkie-talkies too, like you do at Food Line, the drive-throughs. So everybody had a walkie-talkie, so you could talk back and forth staff-wise. No, patients didn't.
Well, I'm curious, are you saying like prior to COVID, you guys didn't like use a phone system like the Halo?
We did not have it to that extent. We did use the Halo, but we did more. We're close. We're all together.
Yeah, that was us. We just like walked around, I feel like.
Yeah, because we're so close together.
Got it.
We're not spread out. We're not spread out over a wide variety.
Okay.
The rooms are spread out, like we have like one nurse's station, and then all the rooms are around the nurse's station. Oh. So you'd actually, anywhere you stand in the nurse's station, you can see all 16 rooms.
Got it.
So
that makes sense. I think So something you said, just going back to prior to COVID, when you kind of talked about safety of like staff members, and I think we all tend to kind of forget that is important for us as nurses and other staff members in the facility to be safe. And that kind of reminded me of like a couple of instances where we had visitors come in. At first, our visitation hours was just 24/7. You could come in at any time, and just when the doors were locked, you could just be buzzed in. But we had several times where visitors would come in and they would upset our patients so much that they couldn't stay. And we actually had a couple of times I can think of where friends or family members of staff members came in and we had like altercations. So to improve that and to decrease those sort of things happening, we did end up cutting visitation off at 8 p.m. and I believe at 6 a.m. No, or 7 a.m. or 8 a.m. to 8 p.m. we could have visitors. Patients were still allowed to have visitation overnight, but they had to make sure that they were in the building before 8. And if they were going to come after 8, they had to be approved. So anyway, that just kind of reminded me like, oh yeah, safety for us as well. But to talk about during COVID, I think communication was like our biggest downfall. And that to me kind of contributed to unsafe practices. I just feel like policy changes were not conveyed effectively. And when I say that, it was kind of like and I understand things change so rapidly. Like one day this was appropriate, and the next day there was a different change. But I think more than ever, having in-services would have been very important. And that's something that didn't happen. Like, I don't know a lot of people that check their work email frequently, but just like every day at a certain time, having an in-service between the morning shift and night shift could have helped with, hey, this is what we're doing today. And until this practice changed, we expect X, Y, and Z to continue. So whether it was testing patients, where to send it, what kind of tests we were performing and where that should go, there was a lot of confusion about that. There was a lot of confusion of what doctors would actually be in the building or who would be present in the building. Because they were like leadership and doctors, they were rotating who would be in what week, just in case of, one of them got sick, everyone wouldn't be out in management and the doctors. But we never knew who was going to be in the building that week. So we never knew who to communicate with. And if we tried to contact someone that wasn't supposed to be working on the floor, they would get upset. So that was something that I feel like could have been improved upon. I don't know if you guys are talking about the same sheets, but we had this all these wall things put up, and it was supposed to be the designated COVID area. But once we received patients that were COVID positive, they were all over. And I don't think there was a single patient in that designated COVID area. So they were everywhere, mixed in with our COVID positive patients. I mean, with our non-COVID positive patients. And then it was confusing as to what the nurse, where the nurse could be stationed when working with that patient. Of course, they weren't expected to be in the room, but they were expected to be close by. Then it was like, oh no, you are more than welcome to sit in an empty room. Oh no, you're more than welcome to stay in the break room. But I mean, the break room is where we only have 2 break rooms. Which one were they allowed to be in? The one closest to the patient's room, or was there a designated COVID break room? And then that's important to know, because you want to minimize contact with anyone who's having contact with COVID positive patients. So, I mean, it was all very confusing. And like I said, I don't think there was a lot of communication and clarity of what should be happening. And And I think having it in service and just communicating things effectively could have made things a bit safer, because a lot of our, I hate to say it, but a lot of our staff members ended up contracting COVID, unfortunately. And just also, we were floated to different facilities where maybe a week or two later, we would get a phone call saying, hey, you actually worked with a patient that was COVID positive. We need you to come in and get tested. By then, you've already worked with other patients, worked with other staff members. You've already gone home to your family, you know?
Do you feel this, does that happen on your area too, Cody, or no?
It used to really bad. And then, I mean, now at this point, if you have a COVID positive patient and you don't know they're positive and you leave, they never tell you they're positive, which is fine.
Exactly.
I mean,
You don't.
it doesn't matter. If you get sick, you're going to get sick. And if not, it's oh well.
I'm sorry, go ahead.
Oh, that was it. That's all I got.
We had a huddle. We called it the COVID huddle every 6:45 at night. And when we come in, and they would, that thing we got from corporate or whatever that went from what was the day for pandemic, whatever. So we went over that every morning, every night at 6:45 and every morning at 6:45. And then we would throw it, we had like a notebook. So if you got a chance, they would throw it in there. So we had a little bit more communication, which I was very appreciative, because you don't have time to go running in there and check your emails every day. So that helped us tremendously. But you're right, it changed daily. And if you didn't have the communication, you didn't know what the heck was going on. And then it started out as everybody, it's crazy. We got to do this, and this. And then it's kind of laxed where we kind of not doing anything anymore except wearing your PPE. But that's what we're supposed to been doing to begin with for everything. You know what I mean?
Right.
So
so where I work, we have the building. So I work in an inpatient rehabilitation hospital, and our building is shared between two hospitals, LTAC and us. Okay. And so we have the second floor, they have the third and fourth floors. And it was interesting because they have different rules than we do. So there were times where, like, when they were allowed to have visitors and we weren't allowing visitors within the whole of rehab, they would end up on our floor. First of all, it's always been confusing because one elevator goes to the second floor and not the third and fourth. And you wouldn't know to take the other elevator unless you're familiar with the facility. So a lot of times we have random visitors pop up on our floor, like, we're looking for the third or the fourth floor. And that continued to happen a lot during COVID. We weren't allowed to have visitors. And then just like the rules were different, visitation hours, PPE that the visitors had to wear. And now this whole, I don't know what LTAC is doing, but we're allowing two visitors. I think they're still allowing one. Their visitation times are different. So it's just really confusing there. And I think it's really confusing for the visitors and for the patients. And I was going to say something else, and now I lost track of what I was going to say.
Did y'all have to sign out for your PPE?
No.
When y'all, no, we did. We have like cabinets out from each door, each room, and patients were stealing the PPE when we first started, because we had no mask, we had no that, so we had to sign out for each mask, each gown, and then we'd get some gloves. So that was really weird. But then when we actually run out of gowns, and we're using the yellow gowns that we use for everything. And then now we're back. And we actually had and I think this is cool, we had a employee that wrote a grant, and Harbor Freight donated $1,000 worth of gowns and gloves and a mask to our unit, which I thought was awesome. Yeah. So, again, that's good for this, a staff member writing it to help us. So I don't know if y'all knew that or not, but actually they sent it to Northeast Atrium, and then they divided it between a bunch of people. But I thought that was a neat thing for somebody to do to help us.
Nice. That's the kind of question for us. Like, did we have enough PPE? We did not. It sounds like you didn't either. I think that was like across the board. I mean, now we have tons of stuff. We're fixing to be fit tested. I don't know if you both work at Atrium.
Yeah.
We're getting like the nice N95 mask again,
Mhm.
like the double straps, and it's got like this foam and real metal in it. It's not plastic.
Oh,
And I'm
nice.
like, wow,
Yeah.
that took a whole year for us to get that.
Yeah, I'm a fit tester, so yeah, we've started doing that too.
They're
So-
nice.
They are very nice, and they don't stink as bad as the other ones.
No, and they don't hurt as bad. Like I don't know if you had like the Macrite ones.
Yes,
Those were terrible.
they
Those
were
would
awful.
not fit anything. They never worked. It's like I would just don't even need it at that point.
And then we had all those breakouts, and you had your nose was sore, your mouth was sore, your ears are sore.
Yeah.
I am still suffering from the breakouts. And there's this like little discoloration on my nose that just it's gonna take time to go away, but it's still
Yeah,
there.
that'd be years. Years. That's
Yeah.
there for forever.
Yeah, that might be your permanent scar. You can say, "Look, I have this COVID pandemic scar."
Yeah.
I think we answered them all, didn't we?
I think so. Even if like I know we didn't read one of them out, but we answered it. We went through
Yeah,
it.
you know, it said, "Do you have access?" You said it, and did it change or did it continue? And how is it back to the normal? Yeah, so now we're overloaded with it. I'm sure y'all are too.
Yeah, maybe they should stock up a little in case like something happens next time.
I agree. You
Now,
know,
see, go ahead.
oh no, I was just gonna say, like in regards to PPE, so during my fit testing, I have to wear the half face respirator. I think that's what it's called with the
PAPR, yeah.
filters. Yes.
The pepper.
And so I've been working with Adrian for 5 years. And like I said, I've only been a nurse recently, but I had never seen it like on our unit ever. And every time I questioned it, they were like, oh, they're very expensive to have. If you were really to need one, we'll get one from another unit and you would have to share it with someone. And just when you need it, we'll make sure we have it. Well, lo and behold, COVID comes along and it's
Yeah,
like,
and
I
I
need
got
this. But for half the year, I did not get one. They would assign me to patients that were COVID negative or, didn't have any aerosolizing treatments just so that they wouldn't have to purchase that mask for me. And it became very inconvenient. And sorry, this has nothing to do with what we're really
Mhm.
talking about.
no, but yes, it does. It does.
But it became very inconvenient because if I did have a patient getting a breathing treatment and I had meds to give and I had to wait that whole hour, well, my meds were going to be very late. And I had to keep asking someone, hey, would you mind giving this patient my meds and I can give your patient this meds? But it's very inconvenient to have to stop another nurse and ask if they can do this for me because I didn't have the proper equipment and I wasn't going to risk anything and become a liability for the hospital to work with that patient. Or even like when my patient had to be tested for COVID before going to a sniff, I had to keep asking other people if they could perform the test for me because I didn't have their proper equipment to do it. So that was really frustrating.
I'm sure it was,
But
because you feel like you're not taking the care of your patients that you're supposed to be doing.
exactly, yeah. And then I didn't want it to seem unfair. Like, how come she never gets this more acute trach patient? Well, it's not because I don't want the patient. It's because I can't have that patient because I don't have the
Mhm.
proper equipment. So
That's fair. It's accurate. All right. Well,
Anything?
that's
I
about
think-
it.
Okay.
yeah.
I'm gonna stop recording. I don't know.